Hello and welcome to JCO Precision Oncology Conversations, where we bring you engaging conversations with authors of clinically relevant and highly significant JCO PO articles. I'm your host, Dr. Rafeh Naqash, podcast editor for JCO Precision Oncology and associate professor at the OU Health Stephenson Cancer Center at the University of Oklahoma. Today, I'm excited to be joined by Dr. Wainberg, professor of medicine at the UCLA and co-director of the UCLA GI Oncology program, and author of the JCO Precision Oncology article entitled Prevalence of FGFR2b Protein Overexpression in Advanced Gastric Cancers During Prescreening for the Phase III FORTITUDE-101 Trial. At the time of this recording, our guest disclosures will be linked in the transcript. Thank you for joining us today, Dr. Wainberg.
Thank you.
So this is an interesting topic where we are going to discuss about markers, therapeutic targets potentially for gastric cancers. So to start off, since we have a very diverse audience comprising of trainees, community oncologists, academicians, could you tell us what is the current landscape of treatment for gastric cancer based on some of the markers that have had, IHC markers that have had FDA approvals recently?
So in gastroesophageal cancer, which includes primarily adenocarcinomas of the distal esophagus, GE junction, and stomach, we have a number of IHC diagnostics which we use routinely in patients with advanced disease to assign potential therapy. The most important is probably MMR proteins, which obviously would confer microsatellite instability and which would leave us with a strong therapeutic option with checkpoint inhibitors. That's probably, if you had to identify what would be a priority test, that might be it. HER2 is in some ways also very, very important and has been around the longest in some respects, which is overexpressed in about 20% of patients. And PD-L1 testing is now considered very important to assign therapy for checkpoint inhibitors with chemotherapy. So if we had a typical patient, you wanted to get your pre-critical IHC diagnostic tests, you're going to do MMR, HER2, and PD-L1. The fourth one, which is relatively new, is Claudin 18.2, which is a fairly new target, only of a year or two old, in gastric and gastroesophageal cancers. Also probably overexpressed, at least the classical cutoffs at 30-40%. So those are considered to be the standard options for patients with advanced disease.
What I have known a little bit about is FGFR2, FGFR3. Before I read this article, I did not actually know that there's FGFR2b. Could you help us understand why that subcategorization is important there from a target standpoint or from a therapeutic standpoint?
So FGFR2b is an isoform of FGFR2, and it's considered to be the more important clinically isoform for the purposes of certainly signal transduction, and blockade of it, therefore, felt to be important. So FGFR is a fairly confusing topic because it can be mutated, amplified, or overexpressed, all of which have been studied in various cancers, all of which have been the subjects of different targeted therapies in many scenarios. When it comes to gastric cancer, what makes it somewhat unique is that it is both overexpressed on the protein level, and that's the purpose of this study, to really put some granularity behind what degree of overexpression, and amplified being about 5%. Those are the true amplified patients, just like in some other scenarios, such as HER2, there's a percentage of patients that are truly amplified. So amplification always equals, in this context, overexpression, but overexpression does not always equal amplification.
Interesting concept between, I've always at least tried to understand this, but the one aspect that seems, and I'd really like to hear your thoughts on it, is mRNA expression. So what are your thoughts on the mRNA side, how that correlates with IHC for some of these targets, especially FGFR, and perhaps therapeutic benefit from some of the targets that are currently approved for FGFR, especially in cancers related to the gallbladder or cholangiocarcinoma for that matter?
So in those cancers, where we have approvals of FGFR, it's usually because of a translocation, which obviously is an active target in cholangiocarcinoma. We've got a number of FGFR2 inhibitors. They actually don't just inhibit two, they vary in how many kinases they inhibit. The 1 through 4 are considered to be the main ones. All of the novel generation FGFR inhibitors are a little more specific. But generally speaking, it's because of the translocation. Here in gastroesophageal cancer, there is some data for mRNA expression, but it's not that common. The data, I should say, is not that plentiful. So we don't know exactly the correlation. What we do know is that using cutoffs of IHC, which is the protein level, we do probably see about 15% of HER2 negative patients being positive for FGFR using at least the predefined cutoffs that were determined for the purposes of this study.
Going to the background of this study, from what I understand, the FORTITUDE trial, I think there's published data from the Phase II study that shows benefit. Could you tell us a little bit about that and the antibody that targets the FGFR2, which is why I understand you looked at the IHC expression patterns in gastric cancer here?
Yeah, so the background of this whole story, which I've been involved with for some time, unfortunately now has probably become even more confusing, and I'll explain, is based on the premise that you can target FGFR2 in 15% approximately of HER2 negative gastric cancer. So the first study we did centered primarily on that group of patients, and the response rate was pretty low, only about 15-20%. So then we said, well, as an antibody, we should combine with chemotherapy. So we did a randomized Phase II study called the FIGHT study, which randomized patients to either FOLFOX placebo or FOLFOX bemarituzumab, which is the name of the antibody that blocks FGFR2b. And the study showed that the group of patients who had FGFR2b expression, as defined in the protocol, which was categorized either as greater than 5% or 10%, we'll get to that in a minute, there was a statistically significant improvement in overall survival and progression-free survival, and some really interesting data that suggested there was real benefit in that group of patients. Now, at that time, the molecule was purchased by Amgen, and Amgen launched 2 randomized Phase III trials while also simultaneously going back and looking at the original FIGHT data. And what became clear, if you went back and looked at the original FIGHT data, is that the greatest benefit was in the group of patients who had greater than 10% staining. So now, instead of having probably somewhere around 30% or 28% of HER2 negative gastric cancer, went down to about 18%. And so we eliminated from the study the patients who had less than 10% staining by IHC, really to hone in on that group of patients. So 2 studies were launched. The first one was FOLFOX with or without bemarituzumab, called FORTITUDE-101. The results of that have been released, showing that while statistically significant for its primary analysis of overall survival, with longer follow-up, the medians came together. What that suggested is that there was a large attenuation of the benefit in overall survival in that study. And for some reason, stuff we're still trying to figure out, we weren't able to replicate sufficiently the Phase II results in the Phase III. Simultaneously with that, we also launched a second study, FORTITUDE-102, which was randomizing patients with the same diagnostic cutoffs to either FOLFOX nivolumab, which has been the standard of care now, certainly for patients greater than PD-L1 greater than 5, for a number of years, with or without bemarituzumab. And that study, which we had high optimism for, unfortunately, that also did not meet its primary endpoint. So this puts us in a bit of a quandary as to how to further target FGFR2b. When we wrote this paper, the purpose of it was first to put out some data with respect to what is the true overexpression rate of this target. Because it is prominent to have a group of patients who are 15 to even 20% overexpressed. And so that was the main purpose of this study. There hadn't been, to that date, any prospective data. It was all retrospective. So there is value in having prospective data, because even if this drug may not have shown benefit, and we're still waiting to see all the results, so I don't want to speak prematurely, but there may be a subset here that does get benefit, we still have a whole bunch of antibody-drug conjugates which are being developed against FGFR2b. Knowing and understanding the degree of overexpression is actually an important thing.
Thank you for summarizing again and putting the idea into a context. It's interesting you bring out a point that based on the Fortitude 101 and 102, there was no obvious signal. I'm a thoracic oncologist, so going back to the pembrolizumab lung cancer data cutoffs for PD-L1, even there we see if you have 50% and above, they respond really well to immunotherapy single agent. But when you go to the 90% and above PD-L1 positive on the cancer, on the tumor, they are the ones that actually drive most of the responses there. So is that something that you've seen in the prelim data? Because these cutoffs, to the best of my understanding, and perhaps you can explain this better, often tend to be very arbitrary, whether it's 10%, 20%. Do you think if you were to look at that data or previous data that's been published in this space for FGFR2b, that higher percentage positivity actually correlates with better responses versus when you look at that data for antibody drug conjugates, for most of the antibody drug conjugates, especially I do early phase drug development as well, the ability to match positivity with responses has not necessarily panned out also. Could you give us some thoughts there?
So in PD-L1, it took over a decade to get to the place where we are now, where we kind of understand it a little bit better. So FGFR is quite in its infancy relative to that. I will say that one of the things that we're really trying to understand is what is the true rate of amplification, because the amplification data, also retrospective, suggests around 5% of gastric cancer. So what we're doing now is collecting all these specimens, sequencing them, which is the way we check amplification nowadays as opposed to FISH. And then we'll probably get a cutoff of FGFR, which is considered positive, and then understand what is the rate of amplification. Now, we're also simultaneously looking at things like you just suggested, upper quartile, greater than 50, greater than 100. The only thing I will say is that so far, and this is my sense in the literature and even in this study, is that those super high expressors correlating with what you described, PD-L1 greater than 50, greater than 90, are not very common in this entity. So we don't really see a high rate at all of people who have overexpression of, let's say, 90% staining tumor cells. That is just not something that occurs, at least as far as I'm aware, in gastric or gastroesophageal cancer for this protein. It doesn't occur in many scenarios in gastric cancer. We see that just a little bit with Claudin 18.2, which itself is not even an oncogenic marker. But even in HER2, we don't really see the 90% expression levels and things of that nature.
Well, one of the things I really liked when you said it was all the exploratory analysis that you're trying to do, because it does often happen. You have a large trial that ends up being negative. Hardly, any of the exploratory analysis or tissue specimens end up getting used for any subsequent analyses. So it's good to see that you kind of utilize this opportunity to at least move the field forward and then subsequently perhaps look at other co-occurring alterations with FGFR2b in this patient cohort, which is, I think, going to be helpful for subsequent strategies.
Yeah, I think we did do 2 large phase 3 studies with this drug, and that's a total of nearly 800 patients. So we have these specimens, not all of them, of course, but we have a good chunk of specimens that will be looked at very intensively to try to understand a little bit more about this marker, because I actually think personally that this is still a good marker for gastroesophageal cancer. We just need maybe an antibody drug conjugate just may end up being a better strategy, or because we have a large percentage of patients that have a low level of expression, but upwards of 20%. So if you have a cutoff of 20%, you can think about ADCs as we're doing right now with these second generation ADCs and similar proteins and showing early signs of efficacy. So, it's definitely a target. It's just the question of, can we target it effectively? We'll understand a lot more about bemarituzumab in particular as we collect all the tissue and see to what extent patients were amplified and see if there was a correlation there. And beyond that, moving forward into these next generation drugs, I still think it's definitely worth pursuing.
Based on what you've understood about FGFR2b in your work in the trial related work, do you think we should be looking at this isoform in other cancers? Has that already been explored and not necessarily panned out?
It's been explored retrospectively. There have been a lot of studies that have looked at expression rates of FG, and it's not a very for some reason, it's a lot more common in gastric cancer than it is in other cancers. So there has been a small level of expression in squamous cell carcinoma of the lung, for example, and a very small level of expression in colorectal cancer, but seems to be the highest, at least in gastroesophageal cancer. Biomarkers that don't have a genomic translocation, but have more of a amplification correlating with overexpression are a little bit harder. And not everything's as great as HER2. That's what we've realized, at least in this disease.
Thank you again for sharing these insights. The next couple of minutes, I'd like to shift a little focus towards you as a clinical trialist investigator. You're obviously a leader in the field. You've done a lot of work in GI cancer biomarkers. Could you tell us what your career trajectory has been like over the last 10, 15 years, and what kind of insights you'd like to give some early career physicians, trainees who might be listening to this? Words of wisdom.
Oh, okay, sure. I think gastric cancers, gastroesophageal cancers, pancreatic cancers are most of my clinical trials, some colorectal cancer as well. And I've always been interested in new drug development in the space. So many unmet needs. We've come a long, long way. Actually, I feel like, we're going to have setbacks along the way, but overall, you look at it over the last 15 years and how much better it is today than it's ever been before. And this new wave of drug development is even more exciting, I would argue. There's a lot of interest in pharma, in GI cancers and academic collaborations in GI cancers. So it's really a great opportunity at the moment. What I've learned, so first of all, you have to be able to take your lumps, and you have a negative study. If you have something that doesn't work out, you have to, in some way, as hard as it is, brush it off pretty quickly and just move on, because you can pound away at something for a long time. I've been at this FGFR2b bemarituzumab for about a decade, since I started the phase I. It's been a long journey, and even if in the end it's not going to work out as a drug that's developed for this cancer, we've learned a lot along the way, and it's helped in other aspects of drug development. So you have to kind of have the thick skin in this business, I find, to be able to take your lumps and just have multiple things going on so that you can have the opportunities. If some things work out, great. If some others don't, then, that's kind of the way it is. GI cancer has been probably the hardest of the big three to develop drugs for in some respects. We've had our share of failures, but I have to say, like, this next few years, at least, I think will be very exciting. Pancreatic cancer, we've got a whole host of KRAS inhibitors that are making their way through the clinic, active drugs, which for the first time, I think is really proof of concept that these RAS inhibitors are going to work in patients and are working in patients. We've got a bunch of vaccines that are exciting in pancreatic cancer and gastroesophageal cancer. We've got a bunch of new next generation antibody drug conjugates and bispecific antibodies, which are making their way. So you have to be optimistic and still take your lumps and then move on.
Well, thank you again for those insights, and then discussing your career, and of course, talking about failures, which are important to highlight. It's like you said, more about how you move on and how you get up after those failures that define the subsequent success.
You have to be able to learn as much from your failures as from your successes, right? If you're not doing that, it's probably not a good field for you in some respect. The illusion that everything's going to work is, as we know, not reality.
Absolutely. Well, thank you for sharing, again, your insights. Thank you for publishing with us. And hopefully we'll see more of your biomarker work perhaps get published in JCO PO.
Well, nice to chat with you as well.
Thank you for listening to JCO Precision Oncology Conversations. Don't forget to give us a rating or review, and be sure to subscribe so you never miss an episode. You can find all ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.